Good afternoon, dear friends. I'm happy to present this session about the long journey of the day into the night, which means that we try to show some light in the difficult cases of cardio-rheumatology. And I'm very happy to present my best friend and collaborator, Dr. Daousis, and a case who will present a case of systemic lupus erythematosus. Is a patient that I had the great pleasure to examine together with him and discuss all details of the patient. So we are happy to welcome Professor Daousis in our meeting and discuss the exciting case.
Okay, this was a really interesting case and very challenging, and I believe that it was one of those cases where cardiac MRI was really crucial. So the presentation will be done by our resident, Dr. F.Sideridou, and later on I can make some remarks and discussion. So Dr. Sideridou will take over.
Hello, good afternoon.
Good afternoon to you.
Thank you for the opportunity to present our case. So our presentation will be about when bleeding meets clotting, so ITP and early onset heart attack. So our patient is a 19-year-old female with a personal history of ITP diagnosed at 14 years of age. Her platelet count at the time was 5,000. She underwent treatment with steroids, IVIG, and rituximab. She has been in good clinical condition since, with a normal platelet count, and she's currently under no medication. So at the time of the ITP presentation, she had reported mild hair loss, photosensitivity, and her laboratory results showed a positive ANA titer. She wasn't assessed by a rheumatologist at the time. And back to the present, she presented at the ER, mentioning that since 10 days, she had a fever up to 39, with atypical abdominal pain, chest pain, and dyspnea on exertion. For the past few weeks, she also mentioned exhaustion, anorexia, joint pain of the small and large joints, and mild fever. Before coming to the ER, she had a platelet count of 60,000, so she contacted her hematologist, who instructed her to take Revolade, which is a thrombopoietin antagonist. So at her evaluation, we saw that she had a butterfly rash and small joint arthritis, especially her MCPs and PIPs. But what was quite alarming were her laboratory results with elevated liver enzymes, elevated inflammatory markers such as CRP and ESR, low complement levels, a positive Coombs test, ANA 1 to 1280 titer, and positive anti-dsDNA. But what was most alarming were her troponin levels, which were 36,000. So she was admitted to the cardiological department for further workup. They began with a heart ultrasound that had pathological findings. Her ejection fraction was 55, but patients of her age are expected to have 70% ejection fraction. She also had segmental hypokinesis, mild contractility impairment affecting mainly the left ventricle. We can see at the ultrasound that there is a mitral regurgitation. So we moved further on with a heart MRI. Her laboratory and clinical findings were consistent with lupus, so we thought maybe she had lupus-associated myocarditis, but the heart MRI could shed some light on that. So with the MRI, she had bilateral pleural effusion, left more than right. She had pericardial fluid in the inferior lateral anterior basal wall of the left ventricle, and spotty transmural damage indicative of myocardial infarction. As we can see at the pictures, with the yellow arrows, they show that she had late gadolinium enhancement, which can be indicative of scar tissue fibrosis. So we saw that she had subendocardial infarction due to microvascular occlusion, and the scar tissue was more than 50%. Further on, we moved with coronary angiography. She had normal coronary vessels. So we began gathering all the results. So the butterfly rash, the joint pain, the positive autoantibodies, for example, anti-dsDNA, LA, positive glucoprotein IgM, anticardiolipin antibodies, together with positive ANA titer. She had lupus with secondary antiphospholipid syndrome and myocardial infarction with non-occlusive coronary arteries. So for her treatment, we began with pulses of IV solumedrol. We continued with steroids, 16 milligrams, 3 tablets once a day. We also administered IV immunoglobulin with hydroxychloroquine, and she had once every week 4 weekly pulses of rituximab. She also needed to be administered with antithrombotic treatment with enoxaparin and acenocumarole, and the cardiologist suggested SGLT2 inhibitor treatment along with statin and ACE1 inhibitor. For the patient's follow-up, we continued with gradual tapering of steroids that led to discontinuation without any side effects from the patient. She underwent 2 more cycles of rituximab. Currently, she's under azathioprine, hydroxychloroquine, SGLT2 inhibitor, acenocumarole, ARBs, and beta blockers. Our patient has presented with hypogammaglobulinemia with occasional UTI infections, and her most recent heart MRI shows improvement in tissue restoration and a stable ejection fraction at 55%. Now her blood workup is normal with a platelet count of 255,000, normal urine test, and the most positive is that she's able to work and she has improved quality of life. So in closing, we can see that lupus continues to have multiple clinical manifestations regardless of the patient's age with variable severity. As in our case, autoantibodies are of very high significance. In severe cases like ours, close monitoring is of the essence, and heart MRI has a growing role in lupus cardiological manifestations. I think our case is very important to expect the unexpected. Thank you very much for your attention.
Excellent talk. Congratulations to you and to your fellow. She was excellent.
Sophie, you are very much aware of this particular case because you were involved in diagnosing her, and it was a very tough case indeed. Now, my remarks. If you look at her history carefully, one can notice that this girl always had lupus, despite not having a definite diagnosis until her admission, because her history of ITP with low platelet counts and some arthralgia and the positive ANA pointed to that direction, that this girl had lupus. And if she had been diagnosed correctly, and if she had been on immunosuppressive treatment, this perhaps would never have happened. That's the first remark. Now the second. This patient appeared and looked like having a lupus myocarditis, and that was our initial diagnosis. And I was surprised by seeing the cardiac ultrasound, which revealed segmental hypokinesis, which is not very consistent with myocarditis. In myocarditis, you would expect global hypokinesis. We discussed that with our cardiologists, but to our surprise, they were not very keen in performing a coronary angiogram to rule out coronary heart disease, but they did so when we told them that she had very high levels of antiphospholipid antibodies. So when they heard that she had a positive LA test, lupus anticoagulant, and very high levels of beta-2 glycoprotein 1, then they were convinced that they should perform a coronary angiogram to rule out coronary heart disease. They did that, and indeed her coronary arteries were completely normal. And then we were left with no diagnosis, and we desperately needed some imaging modality that could show us what was happening to her heart. And I think in this case it was MRI, and MRI was very helpful in establishing a diagnosis of a myocardial infarction, to be honest, without occlusive coronary arteries. And this was very crucial in determining her treatment, because either she had myocarditis. Either she had something else. She definitely needs immunosuppressive treatment. So that's for sure. But we were unsure about what to do about anticoagulation because this patient did not have coronary heart disease, at least typically based on the angiograms. He had very positive high levels of antiphospholipid antibodies, but we need something to prove that this was a vascular event and the patient would benefit from long-term anticoagulation therapy. And she's a very young lady, and we needed to take to decide on the length of anticoagulation therapy, and this was very critical. So MRI here showed us that this was a major event, a major vascular event. So this should be we should deal with it as it was lupus with secondary antiphospholipid syndrome, and that she would need definite treatment, long-term treatment with anticoagulants.
Exactly, it is correct, and this is the reason that we have to know precisely if it is myocarditis or lupus. And in many cases of lupus or even other ARCDs, we see combined patterns, evidence of past myocarditis with subepicardial scar, and evidence of subendocardial lesions due to microvascular coronary artery disease. That was the case of systemic sclerosis I presented in my talk. We had evidence of myocarditis with mid-wall LGE in various points of the myocardium, and also evidence of myocardial infarction due to microvascular coronary artery disease. So these are the mixed patterns. The MRI not only can clarify if it is a myocarditis or myocardial infarction, but can also give information about various patterns of fibrosis that can be presented in the same patient and have potentially different origin, combined patterns, I mean, which of course make the future of this patient more ominous. And it means that we have to give them combined medication, intensify the cardiac treatment, or even the rheumatologic treatment. So it is of paramount importance to have this information. It's not a luxury anymore. I mean, I know that we are used to use ECHO and we are happy with this, but ECHO, it is just a preliminary guide, not the absolute guide on how to treat these people. MRI can provide this information and can give us more details about the pathophysiologic background and about how to use the currently existing medication, both anti-rheumatic and also cardiac medication.
I agree, Sophie, with that, and this is why we have lowered our threshold for ordering MRIs.
Yeah. And also it can give the evidence of acute disease, whatever it is. I mean, if you have positive T2, it means that it's something recent. If you have no evidence of T2, of positive T2, it's a previous event, a past event that gave us only fibrosis. So it is important to know when it happened something and how extensive it was and where is the location and the morphology in order to make the final conclusion about this patient.
Fortunately, she's doing very well, and she's currently on suppression, and we're gradually completely tapered all her steroids. So currently she's on no steroids, but she's on azathioprine and rituximab, and she's doing well. And her cardiac function has improved. It's not normalized. Significantly improved, and she's doing okay.
Otherwise, her future will include heart failure. Now, with the currently available medication, both anti-rheumatic and cardiac medication, she's okay. She's healthy in practice. So, which is very important because she's a young girl.
Yeah.
So.
Okay. Many thanks for.
Me too.
inviting
I'm grateful for the support I have from you
discussion.
And your team.
Looking forward for further collaborations.
Oh, yeah. I'm yours, you know. Use me as much as possible.
Many thanks. Take care. Good afternoon.
Okay. Okay. Then